Hello, I'm Dr. Monica Peak. On behalf of CME Outfitters, I would like to welcome you and thank you for joining us for today's educational activity entitled A Call to Action for Health Equity, Racial Disparities in the Care of Patients with Cardiometabolic Disease. Today's activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. Today's CME CE activity is also eligible for ABIM MOC points, so make sure you engage in today's events, answer polling questions, submit questions, and provide your feedback. Once you complete today's program, be sure to provide your ABM ID and birth date in the evaluation. CME Outfitters will submit your MOC points. You can also claim this activity as CME for MIPS improvement activity, so please make sure to participate and provide examples of how you will change your practice, and CMEO will send your confirmation of your participation, which you can submit to CMS. I also want to encourage everyone to join us today on our live Twitter conversation at CME Outfitters. We will be monitoring the Twitter feed and responding to your tweets as they come in. One last item I want to note is that we are using an enhanced platform today that allows you to save slides, take notes on slides, answer polling questions, and send us your questions. Please look at the tabs on the left of your screen and give us your feedback on the program and the platform as well. As I mentioned, I'm Dr. Monica Peak. I'm an associate professor of medicine at the University of Chicago, where I also serve as the associate director for the Chicago Center for Diabetes Translation Research. I'm the executive medical director for community health innovation, and I'm also the director of research and an associate director for the McLean Center of Clinical Medical Ethics. Let me start by first welcoming my colleague, Dr. Mark Cohen, who is the chairman of the Department of Medicine and former director of the Division of Cardiology at Newark Beth Israel Medical Center and a professor of medicine at Rutgers. Welcome, Dr. Cohen, and thank you for joining us today.
Thank you. I'm very excited and very flattered to join you, Dr. Peak.
Very excited to have you with us. Also with us is my colleague, Dr. Fatima Cody Stanford, an obesity medicine physician scientist and assistant professor of medicine at Harvard Medical School. Welcome, Dr. Stanford. So good for having you with us today.
Thank you so much, Dr. Peak. It's great to be here with you.
So let's get it started. This is such a vast topic, but we're going to touch today on several important points, including the epidemiological link to cardiometabolic health disparities in minority populations. Our first learning objective today is to identify the structural and social determinants of health that place African Americans, Latinos, and other minority populations at risk for poor outcomes in cardiovascular disease. So we're going to start by an audience response question. So for you in the audience, first, how do you consider social determinants of health when assessing patients with cardiovascular disease for minority populations? A, never. B, sometimes. C, often. And D, always. And I'll say that this is something that we as providers have only recently started thinking about. So I imagine there's probably going to be a range of responses. And so I'll be interested to see what we see come up in the response. Okay, so about half the people said sometimes, which is probably where I expected to see this fall. Dr. Stanford, what do you think about this?
Yeah, I think that this is exactly, what I would have thought, that you have this dispersion where you do have some people that are engaging in and really thinking about this work. But hopefully by the end of this program, we have, always, people thinking about this. So I think that'll be a great shift.
Excellent. So we'll begin starting to think about these social determinants of health. Structural racism being a major driver of that. So structural racism drives these social determinants of health that impact disparities across the board. Dr. Stanford, you've talked about how exposure to such stressors and social class itself affects health. What can you tell us about this?
So what we know is that when we look at the social determinants of health and susceptibility to disease, that there is a strong linkage. And this is part of why when we just did that polling question, we really wanted to have this somewhat integrated into our thinking always. And I really want to get into this idea of economic inequalities, racism leading to higher incidence of cardiovascular disease and other associated disease processes. But let's, look at racism and its link to health. And this is a very basic diagram that you see here, taken from a article that just came out that I helped co-author for the American Journal of Clinical Nutrition, where we look at racism and its link to health by looking at biologic, social, physiologic, and other health outcomes in their intertwined nature, not recognizing that these things are divorced from each other. These things are quite intertwined and together. But let's look at this even deeper. Let's go a little bit further and look at racism and diabetes disparities. And I really, really enjoyed this slide by two of my favorite colleagues at Hopkins, because what this really shows you is racism and diabetes disparities. What you can see here in the center of the slide is we have racism leading to residential segregation, discrimination, and socioeconomic issues. When we look into that kind of column with residential segregation, we're looking at how being of lower socioeconomic status leads to issues like overcrowding, environmental toxins, low health literacy and education level and employment. In that middle column, depression, chronic stress, maladaptive behaviors, all being linked to cumulative biopsychosocial issues, low birth weight, obesity, which is my area, diabetes progression. And then kind of in this far white area, the socioeconomic deprivation issue leading to the uninsured or underinsured, limited healthcare access, lower diabetes prevention and treatment. All of these then culminating in disparities in diabetes-related complication and premature mortality, which we often see in communities of color here in the United States. But I want to hand this back to Dr. Peak to take us through some additional findings.
Thank you. One of the things that we have a lot of data about is racism in society in general and how that impacts health. What we're learning more and more about is how structural racism and interpersonal racism within the healthcare setting itself can also impact health. So as a diabetes researcher, one of the things that I study is specifically healthcare discrimination and how that may impact chronic health outcomes like diabetes. And so in some studies that I led, we were looking specifically at these kinds of associations. And we found that people who were reporting perceptions of discrimination within healthcare had worse diabetes care in several domains, including things like flu shots, diabetes-related primary care visits, and had twice the odds of having more diabetes complications, such as diabetes-related eye disease and foot disorders. And then in a separate qualitative study, we were looking at influences of perceptions of discrimination on interpersonal aspects of care, like shared decision-making. And we found that there are negative influences on that kind of care delivery as well. And there have been other studies that have showed that physician biases may affect treatment in minority children. We were looking at adults, with other studies that look at minority children with type 1 diabetes. And so even when there's equal access to care, there are disparate outcomes as well. So diabetes is just one chronic disease, but we know that there are multiple kinds of chronic diseases that have associations between discrimination and racism. And one of the studies that is a favorite of mine is the Black Women's Health Study. It's an important landmark research study that's been backed by over 20 years of data. It's important to me personally because I've been a participant in this study for decades, since I was a resident at Stanford. So Dr. Stanford, what can you tell us about this data and how it links to obesity?
Well, first of all, I'm just delighted that you have participated so that we could have this great data. My mom is also a participant, so a lot of my favorite people participants in this, what we consider to be the largest prospective study looking at Black women. Particularly what I want to look at is obesity, which is the largest chronic disease of our time. 42.4% of US adults have the disease of obesity, but it disproportionately impacts communities of color. The reason why I want to hone in on this is that in this particular study, we've over 59,000 individuals looking over 20 plus years. And what they did was ascertain whether or not these individuals, these Black women, or middle class and usually above, were experiencing either everyday racism or lifetime racism, and how this corresponded with obesity risk. What we do know is that racism is a stressor. Stressor leads to adipose tissue or fat tissue deposition, and this was increased in the cohort. What they found is that those that reported increased incidence of everyday and lifetime racism had much higher rates of obesity than those that did not. And so this shows that strong linkage between chronic disease and racism. They are not devoid of each other. But despite this, when we talk about obesity treatment access and the disproportionate impact that we see on communities of color, for example, if we want to hone in on Black women, the group that I belong to, we know that almost 60% of Black women have the disease of obesity. Another 20% have what's called pre-obesity or overweight, which means that 80% of Black women here in the United States fall within these categories. But why do we see differences in access as we look at racial and ethnic disparities? I think we need to point out a few things. First of all, there's biases, false assumptions, and knowledge gaps that create disparate cardiometabolic care here in the US and around the world. There's this link of obesity to willpower and just needing to eat less and exercise more, not taking into account other issues that are commonplace and leading to obesity, like medications that are weight promoting, lack of time, psychosocial stress, psychological stress, fatigue, genomic predisposition. These things are hugely important, particularly if we're looking at communities of color. And we're assuming that the patient is not intelligent and won't adhere to regimens without giving them their voice to express what's going on, which may have led to their excess weight. We assume patients are not good candidates for weight loss therapies, which include medications and surgery. And then there's this lack of risk counseling and follow-up care that often happens. A lot of this is secondary to our inherent biases with regards to obesity as a disease, but particularly in communities of color. So let's look at obesity in the midst of this pandemic that we're in. I'm calling this, an intermediate phase or modified phase because the pandemic is not gone.
No.
And what we do know is that these high rates of obesity, particularly in Black and Hispanic women, I want you to see this is some data that is self-reported obesity. And so I want to really point this out. Self-reported obesity rates tend to underreport as opposed to NHANES or National Health and Nutrition Examination Survey data, where we actually have tangible things. But you can see here that there are differences even in the self-reported data. What I want you to also notice is that more than 25% of patients with obesity also have diabetes, and that diabetes raises cardiovascular disease risk factors 2 to even 4 times higher. Black and Hispanic populations do have the highest rates of diabetes and hypertension. But I want to point this out, particularly as we think about COVID-19, its dominance in our life, and what it really has done. And what we have found is that obesity is the #1 risk factor associated with morbidity or mortality with COVID-19. It triples the risk of hospitalization for COVID-19, and it decreases lung capacity, things of this sort. We've seen a quadrupling in the number of patients that are seeking care for their obesity in the midst of the COVID-19 pandemic. But, diet is, one of the more obvious direct factors for cardiovascular disease health, but we often blame the patient when it is also about a lack of access. So Dr. Cohen, do you want to take us through the data on social determinants of health, disparate cardiovascular disease access and outcomes?
I'd be happy to. And the ideas that we have emanate from very, very large studies that are providing a foundation for linking things like glycemic index and cardiovascular disease and death. It is well known that patients who are diabetic clearly have an increased incidence of cardiovascular disease, but even before becoming diabetic, a pattern of high glycemic index food intake, as is seen in many low income and moderate income groups, and as is seen in communities where fast food and inability to access higher quality foods in the local grocery stores or supermarkets definitely impacts those patients down the road. So in this particular analysis, 137 patients were followed. These patients were between 35 and 70 years of age. And they were followed for close to 10 years. And the high glycemic index foods were clearly associated with an excess of mortality compared to a more neutral glycemic index pattern of eating, and also cardiovascular events short of mortality like stroke, myocardial infarction, and rehospitalization. Keeping in mind that many millions of Americans are food insecure and are possibly going to be more gravitating towards a fast food diet or a glycemic diet or a diet that may be more affordable, that sets the stage for this correlation between a high glycemic index and very sinister impact on cardiovascular disease and death. The patients that are relying on food banks also, to a large extent, will end up aiming more for these high glycemic index type foods as well. And so they will a priori be at an increased risk for poorer outcomes. This relationship between glycemic index and cardiovascular death is accentuated in patients who already have diabetes and already have hypertension. So it's almost like a double whammy for many patients in low and middle income groups that are sort of on the fence with regard to their economic status.
Thank you both for this wonderful introduction to some of the causes of disparities in cardiometabolic care. And it really underlies the importance of addressing structural causes now and early for us to have improvements in cardiometabolic outcomes, particularly things like food insecurity, not only for obesity, but also diabetes and cardiovascular disease, and thinking about how we can work more effectively around the poverty that drives food insecurity, as well as collaboratively with organizations like food banks. So we're going to move on to our second learning objective, which is to recognize the impact of bias and health inequity on outcomes of patients with cardiometabolic disorders. So from the data, we know that African Americans are 1.3 times more likely to have obesity compared to non-Hispanic white populations. So Dr. Stanford, what can you tell us about this increased burden of risk?
Absolutely. Thank you so much, Dr. Peak. I really want to point this out because obesity is often the disease that we don't address. We weren't educated about it. And I really want to talk about its impact on really everything else. So let's look at obesity, which we see here in this slide. And we see its impact on dyslipidemia, hypertension, pre-diabetic states, non-alcoholic fatty liver disease, polycystic ovarian syndrome. But we see outside of this circle where we're looking at cardiovascular and cardiometabolic disease, a host of other diseases, mental health issues like depression, cancer. We know of 13 cancers that are associated or caused by obesity, gallbladder disease, osteoarthritis, sleep apnea, dysmotility, and disability. All of these, are associated with an increased risk and burden, which we said is much more pronounced within communities of color. Now, why is this? What is this about obesity? How are we looking at it as a disease? Let me explain how the brain actually regulates food intake. So we're going to take the brain and slice it down the middle. We get to a middle section of the brain in this cross section called the hypothalamus. Now, the hypothalamus is getting signals from different parts of our body to tell us not only how much to eat, it also tells us how much to store. So we're getting signals from our fat tissue, leptin in our fat tissue, cholecystokinin in our small intestine, peptide YY in our large intestine, insulin in our pancreas, ghrelin in our stomach, all sending signals back via the spinal and vagus nerve to tell us how much to eat and how much to store. Now, let's look at this a little bit deeper because you're going to learn some obesity pathophysiology, and let's look at the signaling pathways. I'm going to make sure you know this before we leave. There are two primary pathways by which the body travels, and we're going to focus on leptin, which is signaling from adipocytes, or what we consider to be fat cells. We're going to focus on the bottom portion of this diagram. When leptin binds to this receptor, it stimulates a neuron in the brain called the POMC, or the pro-opiomelanocortin neuron, here in the arcuate nucleus of the hypothalamus. When we travel down that pathway, alpha melanocyte stimulating hormones then bind to the melanocortin 4 receptors and stimulate the production of something called BDNF, which stands for brain-derived neurotrophic factor. Persons that travel down that pathway receive an anorexigenic signal, which means they not only eat less, they store less. As I exclusively care for patients with overweight and obesity between the ages of 2 and 90 as an internist and a pediatrician, my patients signal down an alternate pathway, where leptin binds to a different receptor and stimulates a different neuron in the brain called the AGRP neuron, or the agouti-related peptide neuron in the paraventricular nucleus. We signal down this pathway. Instead, the AGRPs bind to the melanocortin-4 receptors and inhibit the formation of brain-derived neurotrophic factors. Those that have low levels of brain-derived neurotrophic factor receive an orexigenic signal, which tells them not only to eat more, it tells their body to store more of what they eat. Now you may be like, Dr. Stanford, what does this have to do with the social determinants of health? Oh, don't worry, I'm going to bring that home in the next slide. What we will see here is that there was a large study done of over 30,000 individuals. And in this particular study, they sought to hone in on who signals which way. Are there differences by race and ethnicity? And I want you to see here that we're going back to that BDNF. I want to remind you, high levels of brain-derived neurotrophic factor, leaner phenotype, like you see on the left side of this slide. When you have obesity, lower levels of BDNF on the right side of the slide. Now, interestingly enough, those that were of African descent and Hispanic descent out of that 30,000 individuals were more likely to have that CC allele pairing and more likely to have obesity than more non-Hispanic white populations where they had a TT allele pairing and had a higher likelihood of having higher BDNF levels. Now, this is something that people are unaware of. Now, I don't think this is the complete cause of the disparities we see in obesity, but one such explanation for why we see disparate values when we're comparing majority populations to those that are not. And so this is extremely important. Let's look a little bit at this a little bit more. Dr. Peak?
So one of the things that I'd like to do is discuss your specific research a little bit more and talk about some of the access issues around obesity diagnosis and treatment with weight loss and bariatric surgery. So as we pivot, and thank you so much for sort of making sure that we're all level set about some of the pathophysiology that disproportionately affects minority populations to put us at increased risk for obesity. Can you also talk about some of the other factors that are relevant?
Absolutely, Dr. Peak. It's my absolute delight to do so. So when we talk about access issues, we've already talked about the higher burden of obesity within communities of color, but what does that mean in terms of access? We know that bariatric surgery is by far the gold standard treatment for those that have severe obesity or moderate obesity with one of the obesity-related diseases, which includes type 2 diabetes, obstructive sleep apnea, or heart disease. But what happens? Who's getting referred to surgery? So I studied this in a particular study that came out back in 2015 to ascertain here in 2 of our academic centers in the Boston area, who's likely to proceed with surgery? Does this vary? And what we found was that racial and ethnic minorities were just as likely to proceed with surgery if referred than white patients. The comorbid illness burden was similar. Baseline BMI was higher, but what we're finding is that Black and Hispanic and Indigenous people are not getting diagnosed with obesity at the same frequency, despite the significantly higher prevalence. Now, when we look at Roux-en-Y gastric bypass, which is now the second most common form of surgery performed for metabolic and bariatric surgery, this is a study that really shows you the status of affairs back in 2014 when Roux-en-Y was king in terms of being the most frequently performed surgery before the vertical sleeve gastrectomy. What I wanted to show you here is that we've talked about this disproportionate burden on communities of color, but you can see here in this over 108,000 individuals that got surgery that there's a much lower likelihood for racial and ethnic minorities to get surgery, despite the prevalence of or preponderance of us in the population. You can see that there's differences when we're looking at Black patients in terms of issues surrounding BMI, more likely to have hypertension. And when we're looking at serious adverse events, you can also see that there's variation by race in this large cohort of individuals that got Roux-en-Y gastric bypass. Now, when we look at response to treatments like surgery or pharmacotherapy, people have posited that there's differences in response, and these differences in responses may be associated with things such as demographics or clinical features like body mass index being higher, a higher illness burden with regards to comorbidities, quality of life issues, or maybe it's behavioral in nature. Maybe there's differences in eating behaviors, physical activity, alcohol intake that lead to these disparate outcomes. And these may be things that we should consider when we're thinking about individuals that are trying to get access. What are some of the things that may create a differential response? And so, that's extremely important. But, I want to move forward back to Dr. Peak to take us through some additional things.
Well, we have two questions that have come up really quickly. One is specific to this slide, and it asks, are there differences in keeping off the weight after surgery?
No, actually, they're not. That's a really good question. That's one of my favorite topics. We didn't present any of my research on that, but that's like my gold standard. We see that about 25 to 35% of patients who've undergone metabolic and bariatric surgery will have a pretty significant degree of weight regain or either inadequate weight loss. We do not see any significant differences by race or ethnicity. Now, I say that, and I'm going to put a little star in that and say that on average, if we're looking at, for example, non-Hispanic Black individuals, that if we're looking at response to surgery, that there's a lesser loss on average, about 8% difference when comparing non-Hispanic Black individuals to non-Hispanic white individuals. So there's a little difference in the response overall. However, I think that varies. And if you see study after study, you see some that show no variation. And a lot of it ends up being dependent upon the follow-up care and whether or not pharmacotherapy, meaning anti-obesity pharmacotherapy agents, are introduced at the time of NATE or post-surgery or not.
Excellent. Thank you. There was another question that came in, asking me specifically, are there one or two questions we can ask patients that address the social determinants of health in a culturally sensitive way in a limited time visit? And so I'll just make a comment there that the most commonly screened for thing that we're doing now in healthcare systems is for food insecurity, because of its such close association with chronic diseases like we've just mentioned. And there's a 2-item instrument that had been validated in pediatric populations. And then some of my colleagues here at the University of Chicago, Dr. Stacy Testor-Lindau, Jennifer McCloskey, and others have validated that for use in adult populations in healthcare settings. And so you can Google hunger vital signs. It's a 2-item instrument that has now been validated in urban African-American adult populations and many other settings.
I want to just chime in there. We actually recently passed here in Massachusetts at the Massachusetts Medical Society for that to be included with any assessment here done in Massachusetts. So I would like to echo and support exactly what you've stated, Dr. Peak, that this is something that's extremely important, very useful, and it only takes about 30 seconds away from your clinical visit.
Thanks so much. One last question before we move on. Do patients of color also have higher rates of cardiovascular disease and myocardial infarction linked to specifically obesity?
Absolutely. Unfortunately, yes, we do see much higher rates of heart disease and cardiometabolic disease associated with obesity due to the higher burden. We do think it accounts for a significant reduction in the life expectancy that you particularly see in a very pronounced way in Black communities, for example, here in the US. And so absolutely.
Great. Dr. Fatima, what can you tell us about the high incidence of diabetes and patient outcomes in other minority populations? What are we seeing from the data? We've talked a lot about African Americans, but what do we see in other kinds of minority communities?
Absolutely. I think that's a great question. What we do know, I'm going to focus on 2 different groups. Within the Hispanic population, we see differences. I want to show this slide here. Look at this. 20.6% of Native Hawaiians and Pacific Islanders have this issue with diabetes. We see 18.7% of African Americans. You guys have already heard me talk a lot about that. Let's look at the Hispanic and Latinx population, 11.8%. And let's contrast that to what we see in white Americans. When we're looking at morbidity, kidney failure 3.5 times higher in the Native American population. Diabetic retinopathy much higher within the African American population, and along with diabetic complications, where we see blindness, both below and above the knee, amputations, kidney disease, heart attack, and stroke. So going back to the question that Dr. Peak asked earlier from the audience. When we talk about mortality, this is really the sad piece of the puzzle, even more so, is that Native Hawaiians, 22% higher rates of mortality when we're comparing to non-Hispanic white populations. African Americans, 2.3 times more likely to die from disparate income issues with diabetes. And then Hispanic Americans, 1.5 times more likely. So I think you can see that if we look at our major racial and ethnic groups, that we see, unfortunately, higher morbidity and mortality within these groups as it relates to diabetes, as it relates to obesity. And I think that's extremely important.
Absolutely. Thank you so much. We're going to start shift a little bit and start talking about some more areas of prevention. And we have a couple of questions coming in that are related to that. Dr. Cohen, the poor outcomes in cardiovascular health that we see in many minority populations are the result of disparities in cardiometabolic disease prevention as well as care. And so what are you seeing in your patients in the data?
The first thing is that we need to respect the fact that all of these disparities and all these inequities have a very, very unfortunate, sinister impact. And the impact is straightforward. If you look at the numbers on this slide, it's a little bit shocking. Close to 50%, 47% of Black patients will experience CVD sometime in their lifetime, and that number is expected to go up to an even 50%. We all know, and this is now established pretty clearly in many of the epidemiologic assessments and analyses, that there is a lifespan disparity between Black Americans and white Americans. In other words, Black Americans have a significantly shorter life expectancy. We can attribute 1/3 of that decreased life expectancy to cardiovascular disease. And as by now the audience should be sensing, things like diabetes, things like poor quality food intake, the glycemic index, things like diabetes and obesity together, hypertension, all of these things gang up on the minority populations and especially the Black Americans to reduce their life expectancy. And the mechanism of that reduction very often has to do with a cardiovascular event. Specifically, African Americans are 2 to 3 times as likely as white Americans to actually suffer a fatal cardiovascular event. And one of the unfortunate statistics in Native Americans and other minority population is that they experience a much higher mortality rate from CVD at a younger age. So in fact, 36% of Native American Indians under the age of 65, compared with 17% in the overall American population, die at a younger age. And that's very unfortunate. If we look specifically at one of the cardiovascular diseases, which is very common and a very big burden on health care, per se, in the United States, is heart failure. And if we look at heart failure in relation to race, we see these different colored lines identify very, very clearly a disparity between Black men and women relative to white men and women. And we can also look at age differences. So on the far left, you actually see racial disparities in mortality in the younger age group between 35 and 64 years of age, where Black men experience the highest rate of heart failure related cardiovascular death. The differences are not quite as extreme in older patients, but still Black males and slightly less so Black females still have higher rates of heart failure related mortality in the older age group. So this disparity is pretty well established. If you proceed to look at some of the disparities in access.
Dr. Cohen, I'm going to just one second, because we have a few questions coming in.
Sure.
When you had showed us the slide about Native Americans, there is a question about whether or not those rates were similar in Alaska Natives. And I know that a lot of times some of the problems with the data we have is that there's a lot of clumping of data, and we can't sort of parse out some of the differences we see in subpopulations. But do we know if the rates are similar for Alaska Natives?
Yeah, I can't say that the numbers are similar, but I can tell you that in a generic way, Alaskan Natives population is usually subsumed within the Native American population, but I can't say exactly what fraction of information comes from that specific subgroup. But in general terms, those patients behave in quite similar ways as an average, quote unquote, Native American population.
Great. I'm going to ask one more question because two came in that are similar. I know we're going to get to strategies, but just as a big picture idea, as you're talking a lot about disparities in cardiovascular risk and disease so early in life, does this mean that we should be more aggressive for racial and ethnic minorities earlier to try and prevent disparities later in life for cardiovascular morbidity and mortality?
Well, the impact of racism takes its toll in patients at a younger age, and therefore the person asking the question is absolutely correct. And later on, I will emphasize this as a core feature of my interest here, and that is to try to start early. As I'm sure Fatima Cody Stanford will agree, that a lot of the things she sees relating to obesity start at a young age, and therefore our biggest hope is to try to get into the younger age group and either change patterns or have more impact and try to really take down some of the structural barriers to the reaching younger people and helping them get directed towards a healthier lifestyle in order to avoid what will inevitably happen, which is to have a premature mortality.
Great, thank you.
So we do want to highlight major differences in cardiovascular care access, which have been studied very, very well. You'll see that many of these studies are not even that current. That is to say, these differences have been clear to us, those of us who read the published scientific literature for decades. So, for example, minority patients who present with heart failure to our hospitals. And keep in mind, we're not just talking about systolic dysfunction, but within the African American community, there is a large percentage of patients with diastolic or preserved ejection fraction heart failure. But regardless of whether it's reduced EF or preserved EF heart failure, the number of African American patients referred for more specialized cardiology care is shockingly less than the number of white patients referred to specialty care. Why is that important and why is that so sinister? Well, it has been established in prospective studies and a few retrospective studies that referring heart failure patients to more advanced levels of care results in fewer readmissions, and it results in better long-term outcomes, and even in some cases results in better diagnosis, like, for example, the unusually higher prevalence of amyloid, certain types of amyloid-related cardiomyopathy. So the benefits of being referred to a cardiology service a reduced readmissions, a better diagnosis, are less likely to be afforded to our African American patients, according to these studies. In an unfortunately similar vein, if you look at some of the more recent, more glamorous interventions related to structural heart disease, we continue to see these very glaring kinds of differences between non-Hispanic whites and African Americans. So, for example, in TAVR, a procedure that I have done multiple hundreds of at our hospital, the average patient, 91% of the patients were white, and a very small minority were African American. The mitral valve repair with the mitral clip intervention, again, close to 90% being white. And the left atrial appendage occlusion for atrial fibrillation, again, even more than 90%, 92% being white. You're almost tempted to think that African Americans never suffer from atrial fibrillation and never bleed from anticoagulants based on this percentage of patients having left atrial appendage occlusion being almost completely white. So this is a very unfortunate inequity, and these inequities do impact on outcomes eventually. Something as seemingly unrelated to race, you would think cardiac resynchronization therapy for patients with left bundle branch block and cardiomyopathy, again, a very, very disproportionately high level of whites compared to blacks being included for receiving this type of therapy. So from my point of view, the access to care, specialty care, and the inequities in actually receiving certain of these interventions leads to poorer long-term outcomes. And these are things that we in the current era in 2021 need to really focus attention on. Dr. Peak?
Excellent. Thank you so much. And you have partially answered one of the questions that came up already, which was about access. And sort of, but I think the deeper question is sort of which is more of an important barrier, access or knowledge of risk. And so the question is, do patients avoid seeking care because of access or knowledge of risk? And I'll toss that out to both Dr. Stanford and to Dr. Cohen.
Well, in my opinion, the hesitation about care is fundamentally related to engagement. If you open the door and walk into a patient's office and just kind of like look at the chart, and they've had multiple admissions for heart failure, maybe they're not as careful with salt, you could just tell the patient, you're here because you're not careful with salt, be more careful with salt, and then sign off. Mm-hmm. The bottom line is patients who are not that healthcare literate need more of your time. The bottom line is that patients may have different reasons for why they may be more or less adherent to their medications, for example, and that takes a little bit more of your time. And as Dr. Fatima Stanford highlighted for us, there are some very fundamental differences relating to the biology of obesity that even I didn't appreciate until a few minutes ago. And that takes time to sort of help people better understand. And so I think a lot of the maybe hesitation or feeling, you know, it's okay, doc, thanks, I'll just go back to doing what I'm doing, relates to how interested you are as the healthcare provider and how engaging you are. And then once you're engaged, I think the patient will reward you by themselves coming closer to you and listening to what you have to say.
Thank you. I think that is an excellent way of framing both the interpersonal and the structural issues that our patients are trying to navigate on their road to their journey to wellness, and that we as physicians have important roles to play in both the interpersonal in engaging patients and making sure they're equipped with all the tools and the information and knowledge and the sort of empathy and care, as well as that we are aware of the structural barriers and are trying to address those and figure out ways to help patients, navigate those as well. And so thank you for that response. And so I'm really excited that I'm seeing a lot of questions come in. We're not going to get to them all as we move forward. I want to make sure that we're getting to the slides. We have dedicated time for the Q&A. So keep sending their questions in, and just know that we'll get to some of them now to make sure that we're having a lively discussion, but that we do have time saved at the end. So we are going to, I am going to loop back because this one question is so specific to Dr. Fatima Stanford, which is, what percentage, and I'm not sure that we have studies about this kind of prevalence, but just the construct, what percentage of obese patients or patients with obesity, I have learned is the better language, but the question is, what percentage of obese patients are addicted to junk food? So getting back to that physiology. So for patients who have the disease of obesity, how are we thinking about the physiology and people's addiction or a relationship to junk food and how that plays in?
Yeah, I don't see it as an addiction at all, actually. I think that it's just differences in how people signal and what people desire, right? So, when we talk about the prevalence of cravings and things of that sort, I'm not a person that really likes chocolate. I know you guys may think she's a little odd now. We thought she was okay until I said that, but that's just not something that I crave. My mom blames it on eating too much chocolate during pregnancy with me. My sister, does that. There's differences. It's not that I actively am saying, "Ooh, no chocolate." My brain doesn't just turn on. We live in an obesogenic environment, right? We have access to a lot of processed, foods, which we know are, in terms of advertising, as traditionally being targeted towards Hispanic, Black, Indigenous communities, but more Black and Hispanic communities, and that's commonplace here in the U.S. But when you target it and then you crave it and then it's cheap, then there's a kind of a downstream effect. I don't really think that it's an addiction itself. Mm-hmm. So what I've learned, especially with using pharmacotherapy for the treatment of obesity, all of these drugs act on the brain to change how the brain sees weight. I'm just going to go through this very quickly. Phentermine, which was approved back in 1959, inhibits norepinephrine reuptake in the hypothalamus. Topiramate stimulates gamma aminobutyric acid. The GLP-1s enhance the pathways that we talked about, the POMC pathway. And so when we're looking at medications, are they really treating the addiction or just changing how my brain then craves certain things? So I'm going to take away that idea of addiction and kind of putting it back on the patient and pull it back to the biology and how strong our environment affects our biology. Hopefully that's helpful.
Yes, it is. Thank you so much. It's so exciting.
All right.
So this brings us to our last learning objective today, and a call to action to end disparities in cardiometabolic care. Implementing healthcare practices targeted at improving outcomes for minority patients with metabolic syndrome and cardiovascular disease. And we've had a lot of questions that have come in specifically about patient education materials, differential guidelines for minorities around treatment, earlier treatment, what we might be doing differently, what in the built instructional environment can we do. So I'm super excited about this last phase of the conversation. So Dr. Cohen, let's start and lead with you. How can reverting from the idea of race-based medicine, which has been super controversial recently, to an idea of race-conscious medicine help us as clinicians reduce cardiometabolic disparities?
Well, the first thing that I think we have to do is recognize as healthcare providers what we've been taught in medical school based on prior built-in kinds of ideas that may not have a scientific foundation. And so, for example, you could see in this slightly complicated chart, but if you start on the left and move to the right, on the top panel, you have race-based medicine. So some of our teachers coming to us and saying, based on race, you will use a different GFR, or based on race, you will use a different BMI, as I'll highlight in a minute based on some of Dr. Stanford's work. Clearly, there are differences, we've just highlighted over the past half hour, differences in medication or medical related issues that are race relevant. And so what we should be doing as healthcare providers is thinking in terms of race conscious medicine, and how does race and what we see in the patient as a disease state relate to one another, not from the point of view of thinking, well, blacks do this and whites do that, as if there's really a scientific basis. And so what we want to do is think through some of these stereotypes that we have. A stereotype that would suggest, for example, that African American men in general are bigger than non-African American men, et cetera, and ask more scientifically valid types of questions that help us as providers. So let's take, for example, GFR as a very specific example. All of us in medical school, if you look at the top panel, starting again from left to right, we're taught about the estimated GFR and how we have to make a special accommodation for Black patients as opposed to white patients. And in fact, there's a number that you have to apply for an equation. What was that based on? Black patients presumed to have higher muscle mass and creatinine generation than others. In fact, this is potentially
back in slavery days, because slaves were, expected to be larger, and so some of these data come, a lot of this is going back, hundreds of years.
A lot of the data, or a lot of the bias?
A lot of the bias.
Yeah.
A lot of these ideas and constructs. Yes.
And so what we should be doing today in 2021 is, number one, making sure that if we see an African American patient who may be increasing their serum creatinine and decreasing their estimated GFR, that we are very, very careful not to just say, oh, he's probably okay because he has an increased muscle mass as his kidney function deteriorates in front of our eyes, and just kind of pass it off like that, without really paying attention. And that's kind of a shame, because that dialysis and end-stage renal disease is a very big, sad problem among many African-American patients. We don't have much in the way of reparative medications for patients who are on the road to kidney failure. And so we need to be extra attentive to trying to help patients as soon as any kind of kidney deterioration or renal insufficiency is observed. The other one, which is kind of my favorite as a cardiologist, is the notion that ACE inhibitors don't work in Black patients, and therefore we shouldn't use them, and all sorts of other kinds of generalities about care that is race specific. In fact, your goal in high blood pressure treatment is real simple. You shouldn't give a damn what works or doesn't work. You should care about trying a drug, seeing if the pressure is improved. If it's not, try another one. There is no real scientific basis to say, oh, avoid this one in Blacks and use this one in them predominantly. We have to be very, very sensitive to being stuck in these kinds of perpetuating these kinds of biases. But what's clear to me also, and Dr. Stanford did some work of her own on this, is the same thing applies to body mass index, where we may be educated to accept a higher body mass index as being, quote, normal in African American patients and being abnormal in white patients. Again, this is based on her work on a complete lack of application of this index to a broad population. She taught us that this kind of body mass index tables are based on populations that were almost exclusively white and had very, very, very small, if any, input from African American patients. So across the board, there are many things that we have carried with us from medical school and from our older teachers that may have stereotyped things for us in a way that isn't optimal. One of the other things that I would like to highlight also relates, as was asked in one of the questions about young people and whether or not we should try to get more involved at a younger age. And this slide is a depiction of what I think is a landmark study that appeared about a year ago. It proved somewhat conclusively that your cardiovascular health, described as high cardiovascular health, moderate cardiovascular health, or low cardiovascular health, was very, very powerful predictor of whether or not you had a premature cardiovascular death or other event like an MI or a stroke. And the differences between low cardiovascular health at a young age versus good cardiovascular health at a young age was that you basically, by having good cardiovascular health, you reduced your risk compared to the low cardiovascular health young people by about 90%, 80 to 90%. You almost prevented, at least in the 30-year follow-up of this study, from you having a cardiovascular event in later life if you demonstrated good cardiovascular health as an adolescent or as a young adult. Now, the good news is that among African American adolescents and young adults who demonstrated good cardiovascular health, in other words, they had better diet, they had less hypertension, no diabetes. The African Americans who did have good cardiovascular health in adulthood and late adolescence, young adulthood, they behaved the same way as whites who had good cardiovascular health, and they as well enjoyed an 80 to 85% lower risk of cardiovascular diseases at a later age. So over and over again, I keep harping on the theme that our interventions of healthcare providers need to somehow be tailored, need to be strategized towards having an impact on adolescents and young adults.
Oh, go ahead.
Yeah, no, I wanted to transition a little bit to the clinical trials.
So before you do that, I'm going to interject two things that I think this slide and the previous one really underscore for me in how we think about race and racism and genetics, and as we're sort of as a nation and as clinicians really trying to put all this together. And what we know is that the genes, there's more genetic heterogeneity within a racial group than there is between racial groups. And so that essentially race is still a social construct. And so when we look at race and the effects of race over time, what we're really looking at are the effects of racism. Race is really a marker for the exposure to racism. It's not my brown skin that's, doing things to me. It's me having brown skin in this society and how I'm able to have access to goods and services, to healthcare, to an obesogenic environment, to, whatever, to not be exposed to the stress of discrimination, all of those things that over time affect my health. And there was a question in here about adverse childhood events and what that means for cardiovascular health. But the other that Dr. Stanford had also been talking about is genetics. And so what we do want to be precise about is the genes that we do inherit. And so most of African Americans in this country came from Western Africa. through the slave trade. And so we can look at things like the founder effect from some of the breast cancer mutations from people at my institution who are trying to look at things like the BRCA equivalent. And as Dr. Stanford has been talking about with her work in obesity and the diseases of obesity, looking at genetic connections. And so we want to be thinking more specifically about genetic connections, but not about, skin color connections. And we want to be thinking about the effects of racism as opposed to the effects of the color of race. And so I think that as researchers and as clinicians, as we're sort of making this mental transition over the past decade and understanding how brown and black skin increases our risk of disease, that and it's really sort of culminated a lot this past year and a half, that these are great examples for us to sort of chew on your past few slides. And so I just wanted to interject that for us as a group as we're digesting what you've just given us. And then I'll turn it back over to you, Dr. Cohen, to talk about clinical trials.
Well, I think what you just highlighted, for example, you mentioned Dr. Cody Stanford's work with genetics relating to obesity. At the end of the day, we have to be scientists. We have to be rigorous. And we're all from Missouri, the show me state. We can't just accept this kind of broad generality kind of stuff. We rely on evidence-based medicine, and evidence comes from numbers. I don't know if you remember, but when she was talking about her genetic study, she mentioned tens of thousands of patients in that genetic analysis about those receptors and the patient going to the right versus a patient going to the left. But here in this slide, I just want to highlight this one point, which is when we have a study like the Paradigm HF study, I'm sure everybody on this call who has anything to do with heart failure will agree with me that this Paradigm heart failure study was a huge turning point, identifying a combination of drugs as being better than an ACE inhibitor drug. And the risk reduction, look how many zeros are in that. So everyone walks away thinking this is huge. But the question is, what do I tell my patient who's in front of me in the office? This study had predominantly white patients, 66% patients. Only 5% of the several thousand patients in this study were Black. Do these findings pertain to Blacks or not pertain to Blacks? We need to make sure that in these large, studies that are mostly done for registration purposes, but at the end also done to try to get a sense of which drugs have impact more than others, we need to make sure that enough minorities are represented so that the concept of generalizability pertains. I have in my hand a recent publication from Jack, which actually scared me a little bit. It says ablation versus drug therapy for atrial fibrillation in racial and ethnic minorities. And it actually makes a conclusion about ablation therapy for AFib that is race-based. It's based on 100 patients in a 1,300 patient trial. 100 Black patients in a 1,300 patient trial, and the conclusion says things about how ablation works in Black patients relative to white patients. I mean, none of us on the faculty are going to be running anytime soon to change our practice based on one study of 100 patients. And I want to make the appeal, number one, to make sure that as many minority patients are represented in our large trials, but number two, to be very careful about looking at very small sample size subgroups and then jumping to conclusions.
Absolutely. So thank you so much for that. We could talk about this for a very long time. I'm going to move back to Dr. Stanford and talk about some action items because we've had so many questions that have been coming in about what to do specifically about obesity. So Dr. Stanford, can you talk about some action items that clinicians can do to address the obesity epidemic, specifically in patients of color?
Absolutely. This is obviously my favorite topic of discussion, as especially as we intertwine this and looking at race. So the first thing I just want us to remember is that obesity is a complex, multifactorial disease process. This is not just about calories in and calories out. I taught you guys a little bit of the pathophysiology. If you want more of that, you could just find me, so we can go into deep, really understanding. And when we talk about food intake regulation, it's complex, which going back to that question that was asked that Dr. Peak said to me about addiction, it's not just about addiction, it's about how our brain regulates what we want, what we don't want, when we want it. That's really a very, very complex interplay of things with you as an individual and the environment. And these things can be intensified within communities of color. We need to recognize that while there is an increased prevalence of obesity in racial and ethnic minority populations, we know that, for example, non-Hispanic Black and Hispanics are almost half as likely to actually get a diagnosis. And so you might be like, well, Dr. Stanford, does that really matter? Well, we know that, when people put a diagnosis, that often means that they did something or at least addressed it or said something about it. So half as likely to get a diagnosis, yet 2 to 3 times as likely to have higher rates of obesity. I think that we really need to be thoughtful about that. Some of the information is said that, there's a less prominent response to medications and to surgery for racial and ethnic minorities. Does that give us any license to just not consider it within those populations? Absolutely not. And so I really think we need to be thinking about that. And we need to employ strategies to address the disparities, many of which have been brought up. As a pediatrician, as an internist, I'm thinking about this across the age spectrum. What am I doing for my children that are coming in? What am I doing for my adults? And how can I help families? A lot of the patients that I see 3 generations, sometimes 4 generations, since we know that weight is more heritable than height. And that's a really important point that I want to get across that I have not done so far, is to talk about the heritability. We often look at parents and children and see parents and children have obesity, but we know that if parents have obesity, there is a 55 to 80% likelihood that the child will have obesity, even if they're breastfed for the first year, if they're eating all organic fruits and vegetables and lean protein. This is the heritability of this disease. And I think we can't discount that. So I really want to be thoughtful about that as we're thinking about obesity. Take action, address this with your patients, actually treat it like we treat any other chronic disease. We don't treat obesity, which causes all these other diseases, and we treat the other diseases. So be thoughtful, mindful about using the continuum of care, which includes lifestyle modification to pharmacotherapy, to endoscopic therapies, to surgical intervention, and use multiple providers, which include physicians, NPs, PAs, psychologists, dietitians, exercise physiologists, all together. I can't forget the bariatric surgeons. They get upset with me as part of this continuum of care. And the goal is to not get them to a number. I never have my patients tell me their number of calories. I don't care. I care about the quality of what they're eating. And I never give them a number or a weight to get to. I want them to get to the happiest, healthiest weight for them. And I think that's extremely important. So I want to pass it back to Dr. Peak as we think about addressing obesity and these key points with your patients.
Thank you so much. That wonderful advice. I want to also make sure that we share more recommendations for ending disparities in cardiometabolic care. And so big picture, we want to make sure that we're all recognizing and addressing implicit bias, discrimination, and structural racism. And that has been sort of our framework for our discussion today. So with shared decision-making, an area that's sort of near and dear to my heart, making sure that we're practicing empathy, respect, and equality, particularly with patients who have obesity and have an additional layer of societal discrimination. People who are obese are the most likely group to have biases against them, more so than by race or any other group. Highlighting how race has been used in the literature to reflect and promote systemic racism, diversifying healthcare providers at all levels, improving access to health insurance and dedicated primary care providers, addressing delays in care and subspecialty referral. Dr. Cohen and Dr. Stanford both talked about that. Increasing the minorities in clinical trials and examining how race has been used in medical research and how we should be using it more appropriately going forward. Race and genetics are poor references. And so I talked sort of ad-libbed a little bit about some of that. Avoid generalizing populations along limited racial categories and not conflating race with biology. And so I already sort of gave us a little impromptu primer about some of that. Dr. Stanford and Dr. Cohen, how can you give us some other additional examples of how we can empower patients within the community setting and what call to action we might have there?
Well, I for one think that one of the more important access points for us, which we may not take advantage of enough, is getting into the schools and making sure that we start our transfer of information, so to speak, and our engagement with people at a much younger age. I feel very, very strongly about it, and I'm very, very disappointed about how our public education is so unhelpful in this regard. And, I would just hope that our societies, ourselves individually, try to be creative and get us closer to younger people so we can make a difference at a younger age.
Excellent. So thank you so much, Dr. Stanford and Dr. Cohen, for this really important discussion. It has been highlighting, inspiring, informative for me, and I hope for everyone who's participated on this podcast. Let me close with SMART goals for what we as healthcare professionals can take away from the conversation today. And that would be SMART goals, as a reminder, are ones that are specific, measurable, attainable, relevant, and timely. So identify inequitable processes and pathways in the prevalence, treatment, and pathophysiology of obesity, diabetes, and cardiovascular disease in minority populations. To incorporate solutions to address racial and ethnic disparities in obesity diagnosis and management, and to integrate best practices to account for differences in prevention, care, and treatment response of minority populations with cardiometabolic disease. And so we're going to end with audience response questions. We're not going to share these results, but we do want the data sort of included for our purposes. So the first one is, how often will you now consider social determinants of health when assessing minority patients with cardiometabolic disease? A, never. B, sometimes. C, often. And D, always. So please select your answer now. Okay, that's excellent to see. I think we weren't supposed to see those results, but I'm delighted that we see that always is 62%. I don't know if Dr. Stanford or Dr. Cohen want to comment on that.
Well, that's what I wanted at the beginning. We have a majority. I'm still there. I'm glad that there's 0 in the never column, so that's great. Though sometimes people, we need, you can come back and see us again and we'll give you some more information. But no, I'm happy that, during the course of this presentation with Dr. Cohen, Dr. Peak, and myself, that we've seen a shift.
Absolutely. So we've received a number of questions already. We're going to try and work our way through some more of those. You can for you to submit more questions and comments by clicking on the Ask Question tab. And you can also email us at questions@cmeoutfitters.com or tweet to at CME Outfitters. So let's see. This is an easy comment. This has been such an enlightening presentation. Please do more of these and share slides on how I can take action and share with colleagues. Thank you. Thank you for the positive feedback. Someone asked about repeating the name of the food insecurity screening tool. And I'm
a hunger vital sign is what it is. And it should be freely available for you to adapt within your setting.
Yes, I'm going to read the two questions that are accompanied in that because I Googled it while we were talking. The first question is, we worried whether our food would run out before we got money to buy more. And then the response is, how often was that true, sometimes true, or never true for your household in the last 12 months? And the second question is, the food we bought just didn't last and we didn't have money to get more. And then was that often true, sometimes true, or never true in your household for the last 12 months? So two easy, quick questions that are, as a lot of healthcare systems are thinking about screening for social determinants of health and acting on those. The most common one is food insecurity. And as recommendations are starting to come down from CMS, they're leaning into housing and food insecurity as the primary ones. Let's see here. What else do we have? Someone mentioned that they struggle with what patient education tools to use. There's so many choices, never sure what is best. So I'll turn it over to Dr. Stanford and Dr. Cohen to have their recommendations, and then I can also weigh in.
Yeah, I'll start there. With regards to patient education tools, with regards to obesity, there's a lot out there. I would say it's underutilized grossly. So there's so many different tools that you can utilize. There is a Weight Matters toolbox that was set up. I'll make sure I get that to the individuals for this program at the CME Outfitters, so that they can distribute that as a free tool that we developed. Many of the professional societies that many of you probably belong to help develop it as kind of like a starting point. Where do you start in the office, even with your visit? I think that that's a great resource as you begin to maybe consider addressing and hopefully address obesity. And then from there, there's additional tools. I would say the Obesity Action Coalition is the number one organization for patients who actually have the disease of obesity. It's a nonprofit organization with over 75,000 patients that belong to it. And I think that a lot of patients feel like they are part of a community. They can get education and things of that sort, but it's a group where they can belong and feel like they can understand the struggles that others that have had obesity have had.
Excellent. Dr. Cohen, any recommendations?
Yeah, my recommendation is there's abundance of tools, but to encourage the patient to use the tool starts with you engaging with the patient. It sounds a little, wishy-washy kind of softy stuff, but that's the beginning, that the patient will actually listen to you and take that step to take advantage of all the things Dr. Stanford's just said. Starts with you as the healthcare provider engaging your patient.
Yes. Excellent point. Someone asked about tools and methods for healthcare providers to measure and check their own unconscious biases. And so there's
I can't wait to do that one. Can I start? Do you mind? That's my favorite question.
Yes, I know, me too. Okay, yes, Dr. Stanford, you take it away.
I'll just take part of it. I think that one place it's really great, and it's not because I'm here at Harvard, but there's the Harvard IAT, which is the implicit association test. And there's different tests for different things that you can look at. You can look at one regarding race. Do you have biases regarding race? Do you have biases regarding gender? Do you have biases regarding weight status? And these are validated tools. If you go to the Harvard IAT or Harvard Implicit Association test, you can take these. They're very fast. So they don't take very long to do. You probably will finish within about 10 minutes with any of these different tools. And it really enlightens you about your own biases. And I do think starting with self, meaning evaluating your own self, is a really great place to start, because then from there, you know how to make action. So I just wanted to say that, Dr. Peak, I'm sorry, I get really excited about that question, but I have found doing the test myself, teaching my students about these tests, you get to learn a lot about where your vantage point is, because we all have biases, whether we like to admit it or not.
Absolutely. So two things I would add to that. First is that the IAT is also available on the CMEO website on the DNI hub. And the thing fascinating about the test is that what it's doing is measuring the speed of two different neural pathways, are basically our conscious pathways and our subconscious pathways. And so it really is measuring our subconscious biases. And so it's sort of like when you're asked to look at the color red versus read the color red, but when it's the color red is written in purple, and so it takes you longer to do that when there's that cognitive dissonance. And so it's those kinds of tests. It'll give you instructions on how to do it, but it's basically, measuring that kind of cognitive dissonance. And so the speed at which, things that come naturally to you versus things that you have to sort of work at that are going against the grain of what comes naturally to you, that difference in speed is measuring sort of what your bias is for. And you can measure it for lots of different things. All right, so let's see here. How can clinicians help patients navigate the healthcare system to overcome structural barriers somewhat? And so one of the things that I'll just say is that I am super excited about a lot of the changes in our health policy landscape, the healthcare environment landscape in general, in integrating medical and social care needs. And so, CMS is leading the way, but a lot of private insurers are also doing this. Ultimately with the belief that it's going to be, a big return on investment. And there have been various investigators in some of the things that I investigate also, but it's also the right thing to do for people who are interested in disparities reduction. But having the healthcare system have skin in the game for trying to address some of these issues around food insecurity and transportation issues and all of the things that make it challenging for people to navigate their way to health. And so for Epic is the largest electronic medical record system in the country. And so Epic has now modules that your healthcare system can incorporate. Prepare is probably the most popular toolbox of screening for social determinants of health that can be uploaded into various platforms. NowPow and Aunt Bertha are probably the most popular commercial products and platforms that interface with electronic medical record that are screening and referral platforms. And so you can screen and refer at the same time. And NowPow has a more aggressive referral process. Aunt Bertha is a little bit more like the Yellow Pages. And so it's not a closed loop referral, but the idea is that you're not just asking people about the challenges in their life, but your healthcare providers, your social workers, your intake staff with the tools to be able to say, oh, and here are resources that I can immediately right now, like I can refer you to a cardiologist, send you to this resources in your community, the social service agency, or this food pantry, or this, X, Y, and Z domestic violence shelter, so that we can, as healthcare providers, begin addressing these structural barriers that are impacting people's health as well. I think maybe we can take one quick more question. Let's see here. Someone is saying, let's see, I'm trying to take a big picture question that we haven't seen. Oh, I'm just going to loop back to this one. Someone asked again about are we familiar with the Adverse Childhood Events Study, and do we have thoughts about its role in obesity and cardiovascular disease? So I'll toss that out to both you, Dr. Cohen, and Dr. Stanford.
Yeah, so I'll start as I think the only person is a pediatrician here, but also an internist. So I love my adults too. It's just the ultimate undecided specialty. But let's talk about adverse childhood experiences. I am familiar with, there are multiple studies, not necessarily just one landmark study, that have really shown ACEs, or adverse childhood experiences, playing a large role in the development of chronic disease. Trauma, whether it be trauma related to issues like racism or sexual trauma, and a host of other issues that do lead to worsened obesity. So what I want to talk about with regards to that is that what we know with obesity is that when there's an increase in stress, we see an increase in what cortisol, IL-1, IL-6, TNF-alpha, MCP-1, and the list goes on. When that happens, adipose tissue goes and stored. It usually goes and stores more in the midsection, as a predilection to store there. Because traditionally, if we look at our evolution as humans, when there was a stressor, it meant that there was like a threat that was an acute threat. The problem is that when you've had an adverse childhood experience or chronic stress, it's not an acute stressor. It leads to chronic disease, these non-communicable chronic diseases, which become more prevalent in racial and ethnic minorities, secondary to a lot of the issues we've talked about during today's visit. When we talk about access to care, we didn't really spending time on pediatrics, but a lot of my research has looked at access to care with regards to pharmacotherapy or surgery in pediatric populations. And we see the same disparities that we see in adults, but we know earlier intervention leads to better long-term quality of life, not just quality of life, actually reduced mortality, et cetera. But if we're not giving access to the people that need it, then we're seeing the widening of the gap of disparities that continues along the lifespan. And so that's my response, is that yes, all of these things do correlate, and the worse issues that we see in terms of ACEs, the compounding of multiple ACEs on top of each other just exacerbates the issue.
Thank you so much. What a delightful hour and a half this has been. Thank you so much, Dr. Fatima Cody Stanford. Thank you so much, Dr. Mark Cohen. And thank you so much to all of our guests who we cannot see, but who have been actively engaged with all of the questions throughout the program and at the end through our Q&A. To receive CME or continuing education credit, including the NP who just sent a question in, for today's program, please complete the post-test on your screen and then click on the Request Credit tab to complete the evaluation and print or download your certificate. I am honored to have been involved in this very impactful roundtable addressing key issues in healthcare disparities. I encourage all of you to visit the Diversity and Inclusion Hub on the CME Outfitters website for videos and additional resources, which we will be adding to every month. I am very passionate, as you can probably tell, about making a difference in healthcare and for our marginalized patients. So please let us know you're doing the very best care you can.